I gotta share my screen first. See, I told you guys, this is hard. All right. Hey, Luke, you want to let me know if you can see this okay?
Yep, I can see it.
All right. So, sedation is a topic that I have a lot of passion for, in great part due to my chemistry background. But I feel like it's something that has become more and more relevant, even though we've been doing it for the past several years. It's become more relevant, and I don't know why. I don't know if it's because the patient contingent that normally suffers from dental anxiety is more likely to seek care post-COVID, or if we've just reached a critical mass in the practice where we're just known for doing sedation. Whatever it is, those of you within the practice all know that we're busier than a one-arm paper hanger when it comes to sedation and sedating patients. Somebody had asked, I think it was Greenbaum maybe a month or two ago, maybe dabbling in this to help the doctors who don't do moderate sedation maybe get more comfortable with mild sedation, and that's something we are going to touch upon today. But the real straw that broke the camel's back came down to a legal bill or a rule that is being proposed up at the Maine Dental Board, and it's potentially going to change access to care for patients in the state of Maine. So what I did is I took all of that and I put it into a presentation, some of the contents I'd already done for previous presentations to the staff. But let's just start with this. Anybody know what that is?
A rock.
A meteor.
A meteor. Meteor what?
I don't know.
Meteorite.
Meteorite.
A
yes.
meteor. Oh, a meteorite.
So this was actually a doorstop that a guy had from 1988. He knew it was a meteorite, he just didn't know if it was worth anything, and it kept his front door open for many years. And then he read an article in the newspaper about somebody having a meteorite that was worth a lot of money. What he didn't realize is that he had a $100,000 financial asset sitting right underneath his nose, acting as a doorstop. So sometimes things of great value are right underneath our nose. And I share this because I think sedation is one of those things. And I'm not saying of great value financially to the dentist, although one could make that argument. It's more about the value to the patients that's sitting right there ready for us to take. Unfortunately, I don't think dentistry has done a good job of incorporating sedation in everyday practice. I think we all know that what dental school teaches is just kind of the foundation, but we've definitely reached a point in dentistry where we have options available to us, and what I'm hoping to advocate for today is an increased utilization in this technique for patients. So first and foremost, sedation is a continuum. Obviously, if you take one Valium, that's very different than if you go to the hospital and they give you a cocktail of drugs, gas, IV, oral, all of the above. There's often a differing level of sedation, and how we define that is important once we start to get in this realm. In order to understand what the different levels of sedation are, let's look at what normally defines how sedated somebody is. First and foremost, the airway spontaneity, or the patient's ability to respirate and maintain their own airway. So if a patient is too sedated, their airway muscles that hold the airway open, our airway is not an open tube. It's actually a flaccid tube that's held open by muscles. When those muscles relax, like when we drink alcohol, they collapse and we breathe less well. Well, if we remove enough of the muscle function, we actually cause collapse of the airway. In addition, there's also respiratory depression, which is a decreased drive from the central nervous system. That's the third one, increased CNS depression. There's an increased drive to breathe. So as we become more sedated, it's really the airway that we're most concerned about. The middle one, decreased level of consciousness, is the body telling us or approximating where the patient might be. So we're using their level of consciousness as a proxy to try to understand what their airway is doing. We obviously have lots of tools, monitors, objective assessments that help us with this, but the level of consciousness is what we're looking to decrease. The problem is it comes with a decrease in airway and increase in CNS depression. Does anybody have, this is 10,000 foot view stuff, but before we move on, does this make sense? Great. All right, so there's different modes of delivery. Obviously, how we administer the drug to the body is important, and let's go over what those are. But before we talk about pharmacological methods, it's important to know that dentistry has other techniques and tools that get patients to a more sedate state of mind. We can think about providing anxiolysis or anti-anxiety, anti-phobia. There's all kinds of ways of describing techniques and methods that get patients to a state where they don't have the phobia of the dentist. So it's important to know that these tools exist. Lots of us utilize them. A calm voice, turning down the lights in the room, not having the assistant come in with a bunch of energy. Maybe if you have access to a door for the operatory, shutting the door. These are all non-pharmacological methods, and they're all very important when it comes to offering sedation for our patients. I would love to dive into this as its own 1 hour session on a Monday night. So if you guys are interested, hypnotherapy and suggestive therapy is a really cool tool that we actually use with our sedation methods. But let's go down the continuum. As we go from left to right, we're increasing the level of sedation. And when we increase the level of sedation, we're concurrently affecting those three items above. So mild sedation was formerly called anxiolysis. Lysis meaning breaking of, anxio being anxiety, so the breaking of anxiety. That's an antiquated term that many of us were probably taught in dental school. This new term, which is defined by the American Academy of Anesthesiology and adopted by the American Dental Association, and further adopted by the Maine Dental Association, is defined as, well, let me take a step back. Mild sedation in Maine is defined as the number of drugs you give in a day. One drug, one dose, one day. We're going to come back to that. In other states, it's defined as the level of consciousness, and we'll come back to that. Just know that each state has a different definition in where the term mild sedation comes from. It's important to know that when you give a pill, let's say you give the patient diazepam or lorazepam, you can't give the patient nitrous if they come in the office that day. That in Maine, that would be considered delivering two drugs. The next step is moderate sedation. Well, before we do that, this is really where I want you guys to focus because I think it's a wonderful tool. Does anybody have any questions about mild sedation? Valium or diazepam is the most commonly used tool. All right, so let's go to moderate sedation. Moderate sedation, we're starting to get the patient a little bit more close to sleeping. Important to know, we never put the patients to sleep. In the dental office, unless you're doing IV sedation, you are not putting patients in the deep realm. Under moderate sedation, we'll look at what the definitions are. The patient's still awake. They might not remember being there. There's an amnesia effect associated with a lot of the medications that we provide with moderate sedation. But the important thing here to understand is there's two levels in the state of Maine. The first is oral. This is what Regan and I do. And then level 2 is IV sedation. Any questions here? This is what DOCS. DOCS is an acronym for an organization called Doctors for Oral Conscious Sedation, or maybe it's Dentists for Oral Conscious Sedation. Keep in mind that there's lots of different training modules out there. DOCS is the leader in this realm. So if you ever want to dabble in this world, I'd love to talk to you. If you want to skip over my suggestions, that's fine. Just make sure you choose docs. The next layer of sedation is deep sedation. This is when the patient is essentially going very much to sleepy land, yet they can still be aroused. Most oral surgeons bring patients into this realm using a combination of gas and IV sedation. The final realm is general anesthesia. It's using more medications, getting patients to a more depressed level of consciousness. These people are out. This is what happens when you go to the hospital and you have general anesthesia. So this is the continuum of sedation available to medicine and dentistry. In dentistry, we tend to focus on the first 4, really the first 3. Thoughts, questions? Did everybody know this? All right, level of consciousness. So if everybody knew mode of delivery, I have no doubt this next tier of understanding will bring you to a new understanding. So on the left side, level of consciousness, the non-pharmacological methods, I'm not going to indicate whether they affect consciousness or not. That's not our area of expertise. But when it comes to mild sedation, according to the American Academy of Anesthesiology, mild sedation is defined when a patient responds normally to tactile stimulation and verbal commands. Really, maybe their eyelids are getting a little droopy. They're very close to what you would see with a patient on nitrous. Now, what's interesting here is, in Maine, this definition doesn't apply to the category of mild sedation. In Maine, it's not where the patient is with respect to a level of consciousness. In Maine, it's defined by the number of drugs they had in one day. It's an antiquated definition that somebody in this group might be trying to change here very shortly. If anybody wants to jump on board, I'd love to have some help. Antiquated definitions don't serve our profession well. I think a general dentist with a mild sedation right should be able to offer some oral sedation and then add nitrous, because nitrous is removed within 5 minutes after flushing of 100% oxygen. So in essence, nitrous is not metabolized by the body. Therefore, the patient is not necessarily sent out of the office with multiple drugs in their system. This distinction is important. So again, I'm going to go over this and then ask if anybody has a question. In the state of Maine, mild sedation is defined by administration of one drug, one dose of that drug, within 1 day. Now, this kind of doesn't make sense, because you could give a patient 0.75 milligrams of triazolam, that's one drug, one dose, 1 day, and they could literally be crawling into your operatory barely awake. But according to Maine's definition, that's mild sedation. But according to the level of consciousness sedation definition, they would actually be under moderate sedation, which is the more accurate representation. We care less about what we gave the patient. We care a lot more about where they are in the continuum of sedation and their level of consciousness and the concurrent level of airway spontaneity and CNS depression. So moderate sedation, where I spend most of my time with my patients, the patients respond purposefully to verbal commands, either alone or accompanied by light tactile stimulation. I like to think of this as the twilight state. So when you go to sleep or you're sitting in the living room and your spouse changes the channel and you wake up and you say, "Hey, I was watching that." And she's like, "No, you were sleeping for the past 10 minutes. We think we're awake, but we're really not." That's the twilight state. And that's kind of where we aim to put patients under moderate sedation. Again, the patient purposefully can respond. That's the important thing here. Now, it doesn't matter if you're giving an oral medication or an IV. Those are different routes, but they're both considered moderate sedation. We'll talk a little bit about the safety and efficacy of those two different routes and the challenges they provide and the solutions they provide. Everybody following me? Somebody must have a question.
Yeah, I do.
Yeah.
Sorry,
Thank you, Dr.
trying to
Greenbaum.
unmute. Okay. I kind of, so in residency, I did, I forget what we called it, my chief conference, basically like my culmination. My one big presentation was on oral conscious sedation, and I tried to find, but that was in Vermont, and I forget what their rules were. I think it was better than Maine with the whole one drug, one dose, 1 day thing. But I always found it weird. Like, well, you give one drug, everyone responds differently, and then can't you just give one person 10 milligrams of Valium versus 5 milligrams versus 20 milligrams?
Right.
Is there a definition of, like, for mild sedation that the one dose has to be a certain amount? Like, you can't just give, oh, well, they only allow me to give one drug, so I'm just going to give 50 milligrams of Valium because I know I want to knock this person out.
Right.
But
yeah, I mean,
like,
I think they're still relying on, maximum recommended doses, LD50s, all of the pharmacokinetic data that's out there. You still have to rely on that, but there's really no parameters other than that prevent you from doing, prevent you from giving a patient under mild sedation conditions too big of a dose where they're actually somebody that shouldn't be driving. I mean, really, mild sedation, you can give patients some diazepam. You might decide that they shouldn't drive, but I don't think the standard of care would hinder you from that, and that's something I might want to look into to further define, because I've spent most of my time in the moderate sedation realm, and I don't let anybody drive. I don't remember the last time I did mild sedation, in great part because in my eyes, the patient that needs mild sedation needs moderate sedation. There's very few patients that truly just want to take the edge off. Most of those people are fine with just nitrous. So I rarely give diazepam alone or lorazepam alone. With that said, I have my moderate permits. So I want to get better at providing some guidance in the world of mild sedation, because I don't think everybody needs to go get their moderate sedation permit, but I think everybody needs to know how to use mild sedation well. That's one of the takeaway messages I wanted to say here. We should really know how to mildly sedate our patients very well. And we'll talk about that. Yeah, Dr. Greenbaum, it's, the definition, I think Maine is one of the only states in New England that has this antiquated definition system.
I have a question.
Yeah, Elena?
Regarding Maine versus New Hampshire rules. Yep. Do you have to do, usually if you go to dental school, or I don't know, actually, our school it provided a program within so that we were licensed for it, like when we graduated. Is there something separate you have to take for Maine, or how does that work?
Yeah, great question. So mild sedation, I believe in every state, it does not require a separate permit.
Okay.
So I think the training you had in dental school is
enough.
I think it's required for all dental schools. So I don't know if your dental school necessarily had a program that qualified you, although
okay,
I wouldn't be surprised if some schools maybe teach moderate sedation and get your moderate sedation permit, but you'd have to have your dental license first. So I'm not sure how that would work. My guess is you guys had sedation training, yes. Oral sedation training using Valium or lorazepam or Xanax. I mean, there's a series of medications used for that purpose. And then depending upon your state that you work in, you would have that ability under your dental license. As soon as you go to moderate sedation, you have to apply for a separate permit, which requires, I think level 1 moderate requires 24 hours of CE by a board-approved continuing education continuum. DOCS is approved by the state of Maine. I can't imagine there's a state in the United States that doesn't approve any of the DOCS programs. Again, DOCS is an organization that teaches this to dentists. They teach level 1 and level 2. Dr. Regan, who's very much enjoying Hawaii right now, he took a course out west because he really wanted to get this going. He didn't take DOCS. He took somebody else that wasn't approved by the board.
Rocky Mountain something or whatever.
Yeah, Rocky Mountain Sedation. Long story short, the board didn't approve his continuing education, so he had to go back and take DOCS a couple months later. And it was a little more complicated than that. Moral of the story, check with your board to make sure that the continuing education curriculum that you're going to take is approved by the board of your state. I can say in Maine, docs is approved. That's pretty much all I know for oral. I don't know if they've approved IV yet for docs. Docs is new to the IV training world, but that's not really the topic of today's conversation. It's more about getting dentists aware of the options available to them. But to summarize, Elena, yes, mild sedation, any dentist can do. In Maine, that's one drug, one dose, one day. So the mild sedation protocol that we typically will use is we give them Valium the night before they go to bed. It primes their GABA receptors so that the medication you give them the next day will have more of a positive pharmacological effect with less side effects. And then the next day we'll typically give them either triazolam, 0.25 milligrams, or lorazepam, 1 to 2 milligrams. I wasn't really going to get into all of the specifics. If you guys want to do all of that, happy to do it. This was more of a 10,000 foot view. How does sedation play a role in the everyday dental practice? And what are some rule changes happening that might change this landscape for us? Deep sedation, basically that's when the patient's asleep and only a painful stimulus gets them up. So a glabellar rub is essentially rubbing between just in the forehead between the eyes, or sternal rub, you do in CPR to try to get a patient out of their loss of consciousness state. That's not a level of sedation that I want to get patients at. I've definitely teetered on the edge of this level. I have my own protocols. Essentially, I stop the appointment, we turn on the lights, give them some Gatorade, and they typically come back. We let them use the bathroom, they come back, and they're typically good from that point forward. Every level of sedation, you should be trained with safety measures of the subsequent or deeper level of sedation. So as a moderate sedation trained dentist, I have to know how to rescue an airway like they do in deep sedation. The hope is I never have to do it, but I have to at least be trained how to do it. So we've practiced with oropharyngeal airways, nasal pharyngeal airways, and things like that. God forbid I ever have to do it. I practiced on a dummy several times. I have an idea of what to do. So if I ever over-sedate somebody, I have at least some basic training in that realm. But the expectation with your permit is to never let a patient get to that next level of sedation. Likewise, somebody in deep sedation needs to know the safety measures that a general anesthesiologist has. Now, these patients are out. So even a painful stimulus does not awaken this patient. So that's the 10,000 foot view definitions. There's a lot more that follows these definitions, but I wanted to keep it very simple. In modern day definitions, it comes down to you ask a patient a question. Did they respond normally? Purposefully, meaning they heard you and they really had to I'm kind of tired, now I have to answer you. To they didn't answer you, but if you provided a painful stimulus, they would then answer you, and then they don't answer you at all. So that's the overview. When it comes to the different arenas of providers and the levels they provide, dentists and dental specialists. So it's important to know that other than oral surgeons, there's not many residency training programs that offer higher levels of sedation. Some perio programs do. I know there's a few endo programs. Obviously, pedo is kind of its own arm. This conversation is all about adults, by the way. When it comes to pediatric sedation under the age of 12, all of these rules do not apply. Kids are very, very difficult to sedate safely. When people die under sedation is typically kids because it's very, very, very difficult and it's something I will never do. So this is all about adult sedation. So we have dentists and dental specialists that routinely do non-pharmacological and mild sedation methods. Then we have dentists and dental specialists with state level permitting that covers up to moderate sedation. That's where Regan and I are. Sorry, if I hit next, there we go. Oral surgeons, their training gets them covered under all the way up to deep sedation. dental anesthesiologist and independent CRNAs go up to deep sedation, and only anesthesiologists or CRNAs under the supervision of an anesthesiologist will get patients to this level. What's important to see here is that oral surgeons can get patients to a higher level of sedation than the best trained general dentist. I don't think any of us didn't understand that, but that's important to know here. Also, dental anesthesiologists and independent practicing CRNAs also cover this realm. Now, why that's important to me specifically, and Regan, is there's patients we can't treat here. There's just some patients, unless they're in la la land, they're not going to be treatable. So either we send them to the oral surgeon, or we find a dental anesthesiologist and a CRNA. This gap right here is really the reason I wanted to talk today. Does this make sense?
The issue with the send them to the oral surgeon is not everybody needs their teeth out, right? So some people need the deep sedation, but they need to do it for a full arch of crown prep, and and I think that's why it's so frustrating. I get that, and I wish it was always, Dr. Regan and I had a patient. We've been trying to get her in for IV sedation. It's like the front office was like, can we give her a referral to the oral surgeon so she can get the IV sedation? But she doesn't need teeth out.
Right.
She needs a root canal. I mean, she could get the tooth out, but she needs a root canal. She needs fillings, really. That's what she needs, and she can't sit for fillings. Even under moderate, she's tried it. It was no good. So yeah, frustrating.
It is, and I hope everybody understands what we're talking about here requires our voice to be heard. Thank you for that, Dr. Greenbaum. So this is the arena where general dentists spend most of their time: mild and moderate sedation. Mild sedation, 1 drug, 1 dose, 1 day. Essentially, that's at one point in time during a day, the patient has 1 drug and 1 dose. They could have 2 pills that add up to a dose. So it's not the number of pills; it's a number. It's a total dose. Obviously, within the confines of the pharmacotherapy ceilings of these drugs. Obviously, you don't want to give 1,000 milligrams of triazolam. 1 milligram of triazolam is a lot, so you have to understand what the ceilings are. But the most common technique is diazepam the night before, and then lorazepam or triazolam the day of the appointment. I threw this in there because I just want everybody to know that benzos really they're consistent. In other words, they work on GABA receptors, which are CNS depressant receptors in our central nervous system. They have a very consistent effect on the GABA receptors. With that said, how they're metabolized in the blood and in the liver, wherever they're metabolized, that varies, and it gives them different half-lives and different onsets of action. We use this to our advantage because there are certain medications or certain clinical situations where we want to get in and get out, whereas there's other ones we want to have them be sedated for a long period of time. The 3 medications we see the most in dentistry is diazepam, which is Valium, lorazepam, and triazolam. Klonopin I've seen used, but I don't think it's necessarily clinically relevant. It's really these 3 here. This is a clinical effect to time chart that I put together. I was trying to find something online. There was really nothing that really talked about this concept in dentistry. I saw lots of graphs like this, but it included lots of medications we weren't going to use. It's important to note here that this is not to scale. This is for illustrative purposes only. With that said, for the sake of today's conversation, it's important to understand the different curves. So triazolam we tend to use for short restorative appointments. Its onset of action is very quick. Its duration of action is very minimal, so that they're not necessarily lethargic for the rest of the day. Lorazepam we use for our longer full mouth rehab cases. The The peak of onset is about an hour to 2 hours, and it has a pretty long clinical effect, sometimes up to 4 hours. Diazepam, which is what dental schools historically have taught, is really not a good medication for this purpose. It can work, it does relax people, but it doesn't have a strong clinical effect. You're not likely to get any amnesia or anterograde amnesia. Essentially, they forget the appointment. Diazepam we use the night before because it has a long effect when we have to do the one drug, one dose, 1 day protocol. And I still use it sometimes for moderate sedation. The way I think of diazepam the night before is I'm priming the receptors. I'm basically occupying a percentage of the GABA receptors so that the next day when I give a medication, there's less receptors that need to be occupied to have a clinical effect. That increases the predictability of the drug that you give that next day. And then there's a series of others, Klonopin and Xanax and others that have very long half-lives that are not clinically relevant to dental sedation. Maybe general anxiety, although benzos in the world of anxiety are becoming less and less common because they're so damn dependent. When our body is used to these medications, it's very difficult to get off of them. The other thing I wanted to say is the longer the half-lives that we have here, if we end up giving a patient our narcotic later in the day, let's say we have a 4-hour appointment, we did an all on 4, and then we give the patient Vicodin, if that lorazepam is still in their system, they can have a resedation event where they take another CNS depressant, the narcotics. So we have to understand the pharmacology of the two and how they interact. You can have a resedation event. The reason this is important is because you want to choose a medication that has the shortest life half possible so that you can give narcotics post-operatively and not have a chance for that to happen. That's not something that happens regularly, but it's something we should be aware of, and we should use that concept as we prescribe. And that is another reason why IV sedation is considered so valuable, because we can get in and out much faster. All right, what time we got? All right. Any questions about this here? Moral of the story is there's different medications for different periods of time that you need to get the sedation, the patient sedated. All right, quantification of the problem. So this, we're switching to the rule change that's been proposed up in Augusta. This is pretty complicated. It's taken me several weeks and lots of conversations with lawyers and nurse anesthetists. I've talked to some people in the nursing board, and I've attended the 2 sessions from the main dental board to try to get a better understanding of what's happening here. In a nutshell, CRNAs are nurse anesthetists. These are people that when you go to the hospital and you get sedated, they're the ones doing the work. An anesthesiologist will oversee 3 of them in the hospital setting. They're very trained. They basically do everything. The anesthesiologist is basically the one overseeing it from a general supervision perspective in the hospital. But over time, there was an increased need for sedation in other areas of medicine, and in dentistry, the CRNAs found their way to the dental office, both helping deeper sedation cases in oral surgery clinics. Obviously, oral surgeons having to manage a deep sedation case in addition to what they're doing is very challenging, so they would hire CRNAs to help. And then CRNAs found their way into general dental offices, helping with this cohort of patients that we talked about earlier. In Maine, the nursing board has not yet allowed or given the green light to CRNAs to practice independently, meaning they can go wherever they want and sedate whoever they want as long as they follow their board's guidelines. In New England, Maine is the only state that doesn't allow for an independently practicing CRNA. With that said, there's no rule against it. So for many years, there's been this gray area where the dental board allowed this to happen. The nursing board didn't really care because there's a great safety record with CRNAs going out into non-hospital settings. But there was an incident that happened at a pediatric office within the past 6 months that kind of changed this tune. Essentially what happened was there was a pediatric patient who had complications with sedation, and the nurse anesthetist, the CRNA that was providing the sedation for this pediatric dental office, decided to send the kid to the hospital because they didn't feel the parents were educated enough or didn't understand enough what to do over the next 5 hours. With that said, nothing bad happened. But since the kid was transported to the hospital, the office and the CRNA had to file an adverse event report with the state dental board. I don't know what happened, but the rumor on the street is that the executive director, Penny Valancourt, up at the Maine Dental Board, she's really the face of the dental board. She prepares stuff. She does a lot of the legwork with the help of her assistants in preparation to present to the dental board, because the dental board is comprised by dentists, hygienists, denturists, public members. There's a lot that needs to happen. She does a lot of the work. So the rumor is, and I think it's accurate, that she saw this happen. Doing what she should do, she educated herself and saw that there was a misalignment or malalignment between the nursing board and the dental board. Essentially, there was a gray area, and she felt it was in her best interest to try to fix that issue, which at the surface, that's great that she's doing that, because her job is to protect the public. If she saw that there was a discontinuation between the different laws, then maybe there should be an alignment there. So they being the Maine Dental Board, proposed a rule change that would force any dentist to get to the level of the nurse anesthetist with respect to training. So basically what that means is if you're a dental office and you want to hire the nurse anesthetist, you have to go and get your IV sedation training, get your ACLS, Advanced Cardiac Life Support training, spend anywhere between $20,000 and $100,000 worth of training, but then go out and hire somebody to do what you just went to learn how to do. So it doesn't make any sense. I understand alignment of statutes and rules within different jurisdictions and different disciplines, different areas of medicine, but I don't think they have the right answer. So Friday, I provided a testimony on behalf of the Maine AGD, basically saying we need a different solution. And this is the part of the data I came up with. So I did this after I did the testimony. I'm going to put this into a Word document and submit to the Maine Dental Board before June 12th. What I'm trying to do here is say, one, there's no problem. Two, your solution is actually creating a bigger problem. And three, why don't we create a task force between the dental board and the nursing board, the Maine AGD, the MDA, the CRNA of New England, basically a bunch of highly educated people in this realm, put them in a room, come up with safe standards for patients that make sense for the general population. So I have a master list of Maine AGD members. I kind of went through and sifted out those that are younger to the profession. I just really wanted to get the people who are familiar with sedation enough to provide some insight here, and this is what I came up with for data. Now, what's important, I tried finding epidemiological data in the literature. There is nothing. I was surprised that there's no data on the quantification of dental phobia in the United States. New Zealand had some stuff, UK had some stuff, but I didn't really think pulling from a different country's cohort made a lot of sense. I think we all know there's lots of patients with dental anxiety, but I wanted to try to quantify this so that the Maine Dental Board had a number in their head to better understand what's going on. So on the left, I have a color diagram. Adult patients in Maine is the entire population of adult patients. The red is the percentage of dental patients with dental anxiety. This isn't to scale, but if we can see here, based on the respondents from the email I sent out, that 37% of patients have dental anxiety. The literature in these other countries, it varies anywhere from 30% to 70%. It's a lot. We all know that. But I also asked a question, how many of these patients require minimal sedation, meaning, one dose of diazepam? And the respondents, at the number of percentage of their patients averaged out to about 10%. And then from that, patients that require higher level of sedation was at 6%. Of the 34 dentists, 7 of them offer moderate sedation, either in oral form level 1 or IV level 2. Of those patients, the ones that require oral sedation, 5%, and then those that require level moderate 1, it was actually 1.7%, so I could have rounded it up to 2, but I didn't think anybody would believe me, so I said, well, let's just round down. I don't think it matters, as you're going to see in a second. So I also asked the respondents to be conservative in their estimates, so you can build that in. This is a big problem, quantified or not. So if we take the adult population based on the recent census in Maine, there's about 1 million adult people. If 37% of those that go to those dental offices that we heard from have dental anxiety, that means 370,000 patients have some form of dental anxiety that would preclude them from seeking dental care. It's a lot of people. Well, then if we break down all of the different levels of sedation that these dentists thought those patients would fit under, we can see this. No sedation. These are people who have dental phobia, but for one reason or another, they don't want the medication. They don't like the way it makes them feel. They don't have the money. They'd rather just white knuckle it, whatever. There's a lot of people fall into that category. The next level is mild sedation. About 100,000 people, that was about 10%, fall under the mild sedation category. I actually think this number should be higher in the other two categories, but that's my version of mild sedation. I educate my patients and I kind of steer them in the arena of moderate sedation, because I was tired of having patients show up for mild sedation and then them being too scared, and I have to tell them, sorry, I can't give you any more medications because this isn't a moderate sedation appointment. So I tend to just say, you know what, if you're scared, you're going to come under moderate sedation. Needless to say, the number of patients that fall under the moderate sedation category in Maine, adults, is 50,000 people. And then the number of patients, this is the important number, the number of patients that require level 2 IV moderate sedation or deep sedation. In other words, they need to be knocked out. Maybe not as general anesthesia would be. I put not applicable here because this isn't offered in a general dental setting. There's about 10,000 people that require this level of service. Everybody follow me so far? So of the clinicians that offer this, we can see deep sedation, those 10,000 people can only be seen by oral surgeons and CRNAs for their sedation services. That's the problem here, because what the State Dental Board is about to do is to cross off one of those. So if we look at this again, oral surgeons and CRNAs, and then level 2, I should actually have this circling just this right here. So this yellow box should only be circling these two red boxes. 10,000 people need to be sedated at a level of deep sedation. Oral surgeons can handle all of this stuff, but as Dr. Greenbaum said, what about all this stuff? What about an occlusal in number 18 that's deep enough that without some form of sedation is going to be a tooth that gets extracted? Is it ethical to just say, well, we're not going to allow you to have that treatment until it needs to come out because only an oral surgeon can sedate you? Meanwhile, you have CRNAs sitting over here saying, hey, I can help. Oh, and by the way, CRNAs have 3 years of training in the world of sedation. Oral surgeons have 6 months. Nothing against oral surgeons. They have a great safety record. But if we're looking at safety, we have to understand that CRNAs have quite a bit of training when it's compared to oral surgeons. So who's going to treat this patient cohort of 10,000 people with respect to that? So I'm waiting on the data from the Maine Dental Board. So the very person that I think caused this problem is also the person that's supposed to be supplying me with the information. I think she's resistant because she knows what I'm trying to do. I'm trying to shoot down her moment of fame. It's funny how that works sometimes, but I'm waiting on the data so I can get a better sense of how many providers are out there? This is from my network of people. I know of 10 general dentists that do IV sedation, level 2. I know of 3 specialists. 2 of them are perio and another is endo. I know of 3 CRNA organizations. One of them is Blue Sky Bio, who we have spent the last year trying to get approved to utilize, only to find out that they might not be able to help us. And then I know of 1 dental anesthesiologist. I didn't define what a dental anesthesiologist is earlier, but these are people who graduate dental school and then they do, I believe it's a 3-year program, and their main job is to provide anesthesia. These people have the same 3 years of training that a CRNA has. The only difference is they're dentists. Well, I don't know if you need to be a dentist to go provide dental anesthesia while a dentist is doing the dentist stuff. So as cool as I think that specialty is becoming, if I could rewind 15 years, it's something I would totally consider. It's just not relevant right now, and they're also very expensive. There's also an anesthesiology organization. You can hire anesthesiologists. I believe there's a group of 20 or 30 of them down in Florida. But as you can imagine, anesthesiologists are very expensive. They're the highest paid medical practitioners year over year. So you can imagine flying them up from Florida to come to your dental office for a day isn't going to be inexpensive. So here we have a map of the independent states. So all of the blue states, CRNAs can practice in a dental office with carte blanche. They're practicing under their license, under their malpractice. The dentist can focus on dentistry, and the CRNA focuses on the sedation. If the CRNA feels it's a dangerous sedation, they can bring in another CRNA. They can bring in an EMT to have a second layer of safety. That's something that many of the groups do once patients crosses a certain level of medical complexity, ASA 3 patients. As you can see, Maine sticks out like a sore thumb. So over the next year, there's a lot of people trying to push this towards the blue. Unfortunately, this recent rule change proposal is actually going to put it in the opposite direction. So thank you. All right. I'm going to send this to everybody. If you guys can, email Penny. This is an example. You guys can copy and paste this, put your name at the end. If you don't want to do it and you don't agree with the perspective I provided, I totally respect that. But if you're interested in helping patients receive a level of sedation care that couldn't be achieved anywhere else, I strongly encourage that you send this to Penny. This is like speaking to your senator, your state senator. When you send the more letters that are sent, she's obliged by law to print these out and provide them to the dental board. The dental board has to read these. I don't know if you can be anonymous or not. I would advocate not to. I think there's no reason not to say who you are here and the town that you're in. Feel free to write your own letter. But I do think that the more that we can advocate for our patients, the better off they are. All right, 6 minutes left. Who's still awake?
Yeah, thanks for doing that. Thanks for going through that.
So part of that was advocating for everybody to increase the number of screwdrivers in their toolbox. This is that meteorite sitting holding your door open, just waiting for you to realize how powerful it is and how valuable it is for your patients. The more you do it, the better you get at it. There's lots of training. There's ways to keep it safe. Benzodiazepines are a very safe class of drugs when used properly. We have a wonderful protocol. Tiffany has been beyond instrumental in helping us craft a very safe system so that we leave no stone unturned. She was getting swamped with sedation and treatment planning, and she had sought out Nicole. Nicole is now focused 100% on sedation. She sends out letters to primary care doctors. Just to share an example of how deep we get into this, we had a patient who was approved for surgery from her endocrinologist because she had blood sugar levels on her continuous glucose monitor of 210, I think it was. Well, coming from an endocrinologist's office, I was a little suspicious because a continuous glucose monitor is not an A1C. Continuous glucose monitors monitor 2 weeks at a time. We basically made the patient go back and get A1C tested. There were a lot of back and forth with the primary care, the insurance company, the patient. Nicole probably spent, 3 hours on this. Moral of the story, the patient's A1C went from a 10.8 down to an 8.8, all because we cared enough to really dig deep and push her medical practitioners to get that number down before we practiced. I would love to say that I would have been able to do that as a chairside clinician. I don't know, but having this extra layer of people being very thorough and diligent provides an extra layer of safety for us. And in this arena of sedation, it's pretty thorough. We leave no stone unturned. And if you guys want to dabble in this and start pushing the envelope with mild sedation, I can promise you it's very safe. ASA 1 and 2 patients, diazepam the night before, lorazepam or triazolam the day of, and you're going to be able to help your patients much better than you did before.
Well, thanks for going over that, Doc. That was good.
Good. Well, I apologize if some of it was redundant. I sometimes don't know where everybody's understanding is. That arena was complex to me for quite some time. So happy you guys found some value there. Alrighty. This is the first NECADE session we end early. Does anybody want to share anything before we sign off? Tough crowd tonight.
Oh, I used though. I'll tell the other guys. I used the. I don't know if you've shown the other docs the granulation tissue burrs you got.
Well, I sent that email out. Do you want to talk about the?
Yes, I don't know if you guys have seen it or not. For those of you who are at the office, Dr. Royd ordered these burrs. They go on the slow speed, but they almost look like. It's not, but it almost looks like steel wool on the end of a shank for a burr. Best description of what it kind of looks like, but it just is really good for removing the granulation tissue. I was doing an extraction, surgical extraction, bone graft socket preservation number 29 today. Vertical root fracture all the way down the tooth. Took it out, and I could have done it with like a number 8 carbide on a slow speed, but using this burr that he ordered, if you have several sets of them, was able to get right in there. You can push right up against the bone. It doesn't take that bone away. It just cleans it all really good and pretty easy to control. It wiped out all that granulation tissue in it was a lot. So took it out in like 30 seconds or less. That was good to go.
He was so excited, he called me just to tell me how awesome it was.
It was cool.
Cool.
Yeah, it's going to be helpful for perio involved teeth, because I feel like a perio extraction is a 2-minute extraction and a 30-minute degranulation. That's what it feels like sometimes. So that's a game changer.
Wiped it out. It was awesome.
We call them SDB, socket debridement burrs, and they come in a kit. So the SDB kit is the term that we'll use with the assistants, and I think we have 3 of them. They come in size 1, 2, 3, 4. They're surgical length latch angles. Cool stuff.
Cool.
All right, everybody.
Thank
Adios.
you.
Have a good night.
Adios.